Caesarean section is the operation that we perform to deliver a baby abdominally rather than vaginally. It's an operation that's becoming increasingly common throughout the world, and there's quite a lot of concern about the fact that the Caesarean section rates are rising as high as they are. In the UK, this perhaps isn't such a big problem because we have excellent medical facilities, because women perhaps don't have very many children, and if they do suffer complications in a later pregnancy because of a cesarean, it's unlikely that this will be in any way dangerous for them. In poorly resourced settings, however, it's rather different. And there, the Caesarean section rates are just as high as they are in the West. This comes as quite a surprise to a lot of people. But if you have access to medical care in India, in Pakistan, in Bangladesh, and other countries which we would regard as perhaps being poorly resourced, the Caesarean section rates can still be as high as 45 to 60%. And we have to ask ourselves why this is happening. And it seems that there's more and more people requesting Caesarean sections, perhaps because they have somehow lost confidence in the process of labor itself, and certainly because they've lost confidence in the doctors who might be looking after them. So this is becoming a very big topic, and one that's being discussed worldwide in our international federation and also in institutions such as the UN and the World Health Organization. Induction of labor is something that we consider to bring about a vaginal delivery when it's not naturally occurring. The commonest reason for inducing a labor might be because somebody's post-dates, and by that I mean they've gone beyond 41 weeks of gestation. And certainly that's the commonest indication here in the UK. But of course, there are many instances when we might think it's safer to deliver the baby rather than allowing the pregnancy to continue. It might be because of risks to the mother or risks to the baby. And what we will do in those situations is consider, is it safer to induce a normal birth, or is it safer to perform a Caesarean section? If we choose to induce the birth, then we have medications at our disposal and also mechanical means that we can use to bring the labor about, to start the contractions and to start the opening of the cervix that has to happen in order for the baby to be born vaginally. Alternatively, we choose a cesarean. Women often ask me, is it going to be better to go for an induction in my particular case and try for a vaginal birth, or will it be better to have a cesarean? And very often it's incredibly difficult to answer that question. Now, of course, it's easy if there's an emergency situation. If the mother's condition is rapidly deteriorating and we have to act quickly, then of course we will do a cesarean. If the baby's condition is very poor, say for instance the baby is very severely growth restricted and doesn't have very much energy, and we have evidence that the baby is distressed even before the labor starts, then of course we do an urgent Caesarean section. There's no question about it. But a more common scenario might be that somebody is at 40 or 41 weeks and they want to have their baby, or there's a need for them to have their baby because of medical reasons. And we're then asked, should I be induced or should I have a cesarean? Now, some women will have a strong preference, and that can then be taken into account. We might say, okay, you'd like very much to have a vaginal birth. We'll try an induction of labor and see if it works. And if it doesn't, we can always decide to do a cesarean along the line. But if women don't have a strong preference, then we have to somehow try to make a decision on medical grounds. And this can be quite tricky. Interestingly, in the NHS, a lot of this decision-making doesn't really seem to happen at all. From my perspective, it's not that difficult to look at the woman, look at her history, and look at her personal circumstances, her individual circumstances, and make a decision. So, for instance, you might be in a situation where you have somebody who's had a baby before, vaginally, so we know they can do it. The baby may not be that big, or it may be a similar size to her previous child. On abdominal examination, we can feel that the head is already quite nicely engaged. And on a vaginal examination, we can feel that the cervix is soft, beginning to open, and the head is well applied to the cervix, and everything looks what we would call favorable. Well, certainly in that situation, I think we can all see that a vaginal birth would be very likely if we were to induce it, and that would seem to be by far the best outcome for that woman. On the other hand, we might be in a situation where somebody's not had a baby before. She's at 40 weeks or 41 weeks. We think the baby's quite large on examination. Perhaps on a scan even, we can see the baby's large. The head doesn't seem to be well engaged. And on the vaginal examination, we find that the cervix is long and closed and firm. It hasn't been dilated before, let's face it. The head is still high, perhaps not well applied to the cervix. And we can immediately see that this induction process is going to be rather more complicated and it might not work. We don't know if that baby's going to fit. And ultimately, we might go through the whole process and still end up with a Caesarean section. And I think it's important that that information is then properly imparted to that woman, that we have a really proper informed decision about that. And then the woman can make a decision as to whether or not she wants to go through that process, whether in fact she might prefer to choose to have a Caesarean section electively. And part of that might even be me saying something like, I think in your particular situation, your chances of a normal delivery are 20 to 30%. Okay, that means that 1 in 3 or 1 in 5 women will have a nice normal vaginal delivery they wanted, but the others will have an emergency Caesarean. And do those women want to put themselves through that process before they actually have the Caesarean? As I say, it's a really complex issue, and I think it's something that should be discussed with each individual woman and should look at their individual circumstances and their individual examination and then reach a decision, rather than what seems to be happening at the moment, which is something rather more hit and miss. I don't think there's a particular reason why Caesarean should be more likely than induction. As I say, though, increasingly women are choosing elective Caesareans, even if they don't need to be induced, or even if there's no other intervention. So perhaps it's not surprising that when we start talking about induction of labor, women are more scared, and perhaps then they might choose the Caesarean, thinking that it's going to be an easier outcome for them. And I don't have any evidence for that. I don't have evidence that a Caesarean is an easier outcome for mother or baby, or that it's safer for mother or baby. It's obviously a different outcome. You have a scar on your abdomen that you need to recover from, whereas perhaps with a normal labor, you might have some stitches in the perineum and you've been through a longer and perhaps a little bit more difficult process. But the recovery seems to be no quicker after a Caesarean. The risk of blood loss seems to be slightly higher with a Caesarean. And whilst there's no obvious benefit, perhaps it's a slightly odd choice that a lot of women will make. And I think many women don't consider that there are some risks associated with it, and there can be risks for the future as well. Obviously, there are no risks to the pelvic floor with a Caesarean, which perhaps might be an advantage, but there are other risks. People can have problems with their scar. And interestingly, as an endometriosis specialist, I also see a lot of women with endometriosis in their Caesarean section scars, which has to be removed at a later stage. And more importantly, we can have problems with the scar in the womb. We worry that the future pregnancy might implant in that scar. And we have increasing evidence now that scars themselves do not always heal so well in the womb. And because of this, women end up with slight defects in the womb in this area, which can lead to period problems, which can also be quite difficult to sort out in the future because they have something called a uterine niche. But perhaps this is something we'll come to another time and discuss in a future video.